cutaneous coronary interventions, transcatheter aortic valve implantation, but he is importantly a pioneer in other structural heart interventions, namely the field of left atrial appendage occlusion, where he has been instrumental not only in performing studies, but also designing devices. And with this being said, we are looking forward to his presentation, which will put the novel oral anticoagulants in context with other non-pharmacological therapies. David, welcome.
It's great to be here with you. I have a question to begin with. You've heard a wonderful group of lectures on an incredibly important topic. How many of you, just a show of hands, were alive April 23rd, 1985? Almost everybody. Turns out that April 23rd, 1985 lives in infamy in the marketing community. It was because on that date the Coca-Cola company said they were changing the formulation for Coca-Cola worldwide for the first time since it had been introduced 99 years before. They said, all of a sudden, we're going to make a change. We think it should be better. And so they then rolled it out, and there was an enormous surge of protests. The CEO of the Coca-Cola company at that point in time received a letter that said, "Dear Chief Dodo, what have you done to change my Coca-Cola that I've been drinking for years and years and years and years and years?" How is that relevant? How does that relate to these three brilliant lectures that you have heard? We have heard discussion about the huge impact of these new agents, these NOACs. And yet the answer to the question was that perhaps 25% of the people are on them. Maybe not even that many. The question is, what are we missing? Either we haven't educated people well enough, number one. Number two, they're too expensive. Number three, maybe they're not as good as we think they are. Number four, what are the things that are missing? Other than the fact that my microphone wasn't on. And so we're then going to talk about some of those issues that we might have been missing. I do have a financial interest in Mayo Clinic, particularly in technology, that I will talk about tomorrow. This is a wonderful series that talks about those things we might be missing. This is an ode to a homeless man. It's a homeless man's funeral. As a bagpiper, I play many gigs. Recently, I was asked by a funeral director to play at a graveside service for a homeless man. He had no family or friends, and so the service was to be at the Paupers Cemetery in the state of Kentucky in the back country. As I was not familiar with the backwoods, I got lost, and being a typical man, did not stop for directions. I finally arrived an hour late. The funeral guy had left, and the hearse was nowhere in sight. There were only the diggers and the crew left, and they were eating lunch. I felt badly and apologized to the men for being late. I went to the side of the grave. The vault was already in place. I didn't know what else to do, so I started to play the bagpipe. The workers put down their lunches and began to gather around. I played out my heart and my soul for this man with no family and no friends. As I played Amazing Grace, the workers began to weep. They wept. I wept. We all wept together. When I finished, I packed up my bagpipes and started for my car, though my head hung low and my heart was full. As I opened the car door, I heard one of the workers say, "I never seen nothing like that before. And I've been putting in septic tanks for 20 years. It was the wrong place, the wrong time, the wrong thing." And so as we think about these brilliant talks, were they about the wrong place, the wrong thing, the wrong people, as we think then about the issue of stroke prevention. What do we know about stroke prevention? We are concerned about that in atrial fibrillation. This is a classic picture from a circulation cover. You can see in panel A that during an echocardiogram, a thrombus was seen in the left atrial appendage, and then to the horror of the echocardiographer, it began to move, and then it came out to play in the left atrium itself, and then it was gone. At that point in time, then the patient had a huge stroke, and it is that we fear the most. What do we know about that as it relates to the use of approaches to prevention of stroke? This is old data now from almost 15 or almost 20 years ago, looking at where stroke comes from. This looks at the location of thrombus in the left atrium, and it turns out that in patients that have nonvalvular atrial fibrillation, most of the thrombus comes from the left atrial appendage. It's about 90% of the time. So that's the target. Do these new agents, do the old agents work for other reasons? That is true, they do. But the target for nonvalvular atrial fibrillation happens to be the left atrial appendage. What is the background? We're familiar with the staggering background that today atrial fibrillation affects about 10 million Europeans. 5.5% of Europeans over the age of 55 have atrial fibrillation. Atrial fibrillation comes closer and closer and closer to each of us as we get closer and closer to 55. The prevalence is going to be expected to triple by 2050, and those patients with atrial fibrillation have 5 times the risk of stroke compared to people without atrial fibrillation. So as we think about societal standpoint, if we take a drug that is somewhat more expensive, somewhat harder to use, somewhat harder to monitor, it has huge implications for society as a whole. In 2010, you can see the stroke cost for the EU was an estimated 64 billion euros. 64 billion euros. What do we know about strokes in this setting? We know that about 20% of all strokes occur in people with atrial fibrillation. I'm not going to take a show of hands in the audience who have had atrial fibrillation. I can tell you that I have had atrial fibrillation. It's an interesting experience for those of you that either have not had it or will have it in the future. And that's going to be a lot of you and us. We know that these tend to be large debilitating strokes by virtue of the fact it's a large thrombus. We know that there are significant limitations in trying to predict who we should treat to prevent stroke, because all of the current prediction scores have relatively poor predictive value with C statistics, as you can see there, that range from 0.6 to 0.7. That's sort of a little bit better than a flip of a coin, a little bit better. But that indeed, oftentimes those risk factors for stroke are the same as those risk factors for bleeding. So we can say to a patient, you're at increased risk for stroke, but you're also at increased risk for bleeding. And so you then have to balance those two. And to a certain extent, it's a crapshoot. You see the patient in front of you, you say you could bleed, you could have a stroke. Which would you rather have? Most everybody's going to say, well, if I can bleed, that would be a bad thing, but I can get a transfusion. The stroke, I may not be able to walk or talk or do something more important to me. But this is what they're faced with. On the left side of this, we have the CHADS 2 VAS score, and that's the score that we use the most frequently. And on the right, we have the HAS-BLED score, and you can see that those patients that are highest risk for stroke are also at highest risk for bleeding. And it is a trade-off. It is a risk-benefit analysis. And that is going to be true for the new anticoagulant agents that you've heard about, as well as for warfarin. And these are the questions that our patients face. If you live in Minnesota, where it snows, it seems like all the time, and there's ice all the time, what is going to happen if you fall? If I fall, can the bleeding be stopped? How about the dollars and cents? If I'm going out to dinner, what can I eat? You hear about I see patients every day in the clinic who say, gosh, I know my INR is a little funny, but I had some spinach. That's a real thing. That's real. Or did I take my medication? Did I forget to take my medication? Or if I'm on a cruise, will the cruise ship doctor know what rivaroxaban is? That's a real life thing. What if I start bleeding? And the cruise doctor says, what are you on? And I say, rivaroxaban. And they say, gosh, how long have you had the sore throat? Goodness sakes. Or what if my joints hurt and I need a non-steroidal? Or what if I have bronchitis and I need an antibiotic? Do I need to check? What am I going to do if I get something and there's a drug-drug interaction? And so we know that at least in the past, warfarin has been the preferred thing, and the patients that I see in the upper Midwest, most of them are still on warfarin. That's the data that's available. Are there some lessons that we can learn from the data? There clearly are, in terms of which patients will benefit from an oral anticoagulant agent. These are some of the pieces of information about warfarin that may be germane. 50% of patients indicated for warfarin do not receive that. We heard that already. Is that going to be the same for apixaban? Maybe. Maybe those things that prevent people from taking warfarin are the same things that will prevent people from taking apixaban or rivaroxaban. They're afraid of bleeding. The reasons for not receiving it range from patient preference to the history of hemorrhage. The second piece of information is about 40% of atrial fibrillation patients have relative or absolute contraindications to warfarin therapy. What do you tell a patient who 2 years ago had a GI hemorrhage? They now come in with atrial fibrillation. Are you going to say, well, these things are much safer, you're not going to have any bleeding anymore anyway? Or what are we going to tell those patients who are contraindicated to aspirin, that you would like to put on aspirin because they are CHADS 2-VASc 1 or 0? From a patient or family perspective, the issue of major bleeding versus moderate bleeding is an issue. But the bottom point of this, the bottom bullet of this, is that more than 20% of patients over the age of 80 stop at 1 year. They're going to stop their medications. We heard people stopping their antihypertensive medications, which usually don't have any side effects. At least that many are going to stop whatever medication we're going to give, whether it's a new oral anticoagulant therapy or whether it's warfarin. They're going to stop it because of concern about cost or drug-drug interactions or concern about side effects related to it. And there are other issues that are germane not only for warfarin, but also for the new anticoagulants, the drug-drug interactions, which are challenging in elderly patients. You're all familiar with the group of patients that you see for a 15-minute visit, and they come in and give you their list of 20 medications. Some of those are herbal, some of those are the real deal. And even with herbal medications, there can be drug-drug interactions, and you're saying, goodness sakes, I'm going to have some trouble here. There are the issues of the pharmacokinetic challenges that we've heard about. When do you draw a blood test if you need it? There are the issues of genetic variability. Are there things that we don't know about some of these new agents? There is the issue of bleeding. The bottom line is that U.S. death certificates from 2003 and 2006 that say that anticoagulants rated first in total mentions of death from drugs causing adverse effects in therapeutic use. The first in total medication use of drugs causing adverse effects in therapeutic use. A huge deal as we think particularly of older patients. And then as we talk about risk of triple therapy, the WIX trial from Europe was incredibly important. It was a small trial. Those patients that are on triple therapy, dual antiplatelet therapy for a drug-eluting stent, and whether that be warfarin or one of the new agents, they're going to increase in terms of bleeding. There isn't any question about that. The final thing would be that group of patients in whom we hope that we will join that group, because we hope at some point in time that we will be over the age of 75 or over the age of 85. We'd like to be in that group at some point in time. Not now, but at some point in time. And as we think about those patients who are unstable, you see them in the airport with a cane. They are unstable. You see them with somebody holding their arm so that they don't fall and trip. That's a group of patients in whom we undertreat. We will undertreat with new agents as well as with the older agents that are available. And so we have these agents, and we've heard a wonderful series of talks about the new agents. And I want to just mention a couple of things. This was an important recent article from Pharmacotherapy. This talks about Rely and Rocket AF and Aristotle and Active W. It looked at the number of patients, and as has been mentioned, there are a huge number of patients. Talked a little bit about the CHADS-2 score, not very much about it, but that's an important indicator for risk. But let's look at this piece of information here, and I'm going to go through this line. Let's look at ischemic stroke, and let's look at the difference using the p-value between the agent and the control. That's the p-value, 0.58, 0.35. Some of them it's dramatically better, but not all of them. Let's look then at hemorrhagic stroke. We've heard about the fact that that is less, for sure, and that's a huge deal. The problem is at the beginning of a stroke, the patient doesn't know whether it's going to be hemorrhagic or not, and you don't know whether it's going to be hemorrhagic or not. It's a stroke that is starting. And then if you were to look at bleeding, this is the data on GI bleeding. You can see here that in the Rely trial, no statistically significant difference. In Aristotle, no statistically significant difference. And in this trial, Active W, it was not reported. What do we know about head-to-head comparisons? We don't have much. This is a meta-analysis from CIRC and Cardiovascular Quality Outcomes that was from this last year. It was 44,000 patients enrolled in the 4 trials that you can list there. This was their conclusion. In general, the composite of stroke or systemic emboli and any stroke were significantly reduced with the new agents, but there was significant heterogeneity seen with any stroke, major bleed, hemorrhagic stroke, and GI bleed. The word heterogeneity is a bad thing in these trials. Even though we've talked about similarity, the other arity word in terms of heterogeneity is a terribly important one, because this is the table from that trial, that meta-analysis. Look at major bleeding. We can see the specific studies, we can see new agents and warfarin, and we can see the line of identity here. There's not a huge difference. Some of the time it favors new agents, some of the time it was right down the center. We have heard the phrase significant bleeding. And you're going to say, is this a significant bleed? Or isn't it? Would that make your serious adverse outcome data? Or wouldn't it? To a certain extent, it depends upon whether you're the one bleeding or not. Think about that. If every time you shave, every time you get a cold and blow your nose, you bleed like crazy, if after you have shaved, you have to go to the office with pieces of Kleenex all over your face, while that is minor, still winds up being a problem. And over the course of time, that is going to be a problem with any of the agents that are available. And so the question is, will these new agents replace warfarin as the preferred agent? We have seen what the guidelines say, but no matter what the guidelines say, the public hasn't bought it yet, or the medical community hasn't bought it yet. You have seen this slide before, the difference in major bleeding between warfarin, dabigatran, at 150 and dabigatran at 110. The most amazing thing about this is that nobody talks about what's going to happen out here. There is absolutely no reason that after 2.5 years the dabigatran curve is going to go like this. It's going to continue. If you're 45 years old, over the course of your life, if you have 40 years of an anticoagulant, it doesn't matter what it is, you're going to have an upfront, close, and personal experience with bleeding. An upfront, close, and personal experience with bleeding, no matter what it is, no matter what agent. That happens with the dabigatran. This is apixaban, the same sort of thing in terms of major bleeding using this specific definition. It's going to be less than warfarin. That is true. It's not zero. There isn't any free lunch. There's no free lunch. It is not zero. Or with rivaroxaban, you can see it's somewhat less than warfarin. Somewhat less, not hugely less, but somewhat less. But it is going to continue over the course of a patient's life. And so as we've listened to those wonderful presentations this morning, we need to keep this in mind from Nietzsche, who wrote, "There are no facts, there are only interpretations." We interpret things differently. You interpret things differently than I do. Depends upon whether you're the bleeder or the bleedee. It's terribly important whether you're the bleeder or the bleedee. And so as we think about stroke prevention, tomorrow we're going to talk about other approaches to it. We've talked about pills today. There are some other mechanical approaches. Given the fact that 90% of the time it comes from the left atrial appendage, maybe we should just occlude that. And we'll talk about that tomorrow. It's not perfect. Neither my friend nor I are perfect. We suit each other admirably, and both pills and devices suit each other admirably. Because we have alternative to drugs, we have surgical left atrial appendage closure, we have the Lariat device, we have the Watchman device, you have the Amplatz or cardiac plug, you have the Wave Crest device. All of these are approaches to the issue of stroke prevention in the setting of atrial fibrillation. This is my last slide. It's a wonderful one. For the last time, we are not there yet. You can only remember having had young kids. You're in a car going someplace. In the back seat, your son or your daughter says, "I got to go to the bathroom. Are we there yet?" No, we're not there yet. We're not there yet. Got a ways to go. It's a great journey. It's great to be here with you to talk about that journey that we're on. Thanks.